the distal colon. So not only have we drawn a piece of shrapnel striking this Union soldier on the left, we've put the entire ulcerative colitis scene on the left side of the sketch. Patients with UC almost always present with diarrhea, sometimes with blood. Bowel movements are frequent and small in volume as a result of rectal inflammation. If you thought the symptoms of ulcerative colitis were bad enough, just wait till you hear about the complications, which can be life-threatening. Fulminant colitis, with more than 10 stools per day and continuous bleeding, is a pretty bad complication. But it's not nearly as terrible as toxic megacolon, a late complication of ulcerative colitis where inflammation extends to the smooth muscle layer, which paralyzes the colonic smooth muscle, leading to severe dilation of the colon and symptoms of systemic toxicity. That's one mega cannon. Toxic megacolon leaves the colon in such a weakened state that perforation is a common consequence. You really don't want that. Perforation with subsequent peritonitis has been associated with 50% mortality in patients with ulcerative colitis. We all know that the North had much higher manufacturing capabilities than the South. More arms, more provisions, and, most importantly, cooler uniforms, complete with shiny new cancer crab belts. Ulcerative colitis carries a higher risk for development of colorectal cancer compared to Crohn's disease. The risk of cancer development is directly proportional to the severity and duration of disease. One of the unique extraintestinal manifestations of UC is primary sclerosing cholangitis, abbreviated PSC. Recall from our biliary Native American sketch that PSC is an autoimmune disorder of the intra- and extrahepatic biliary ducts, hence the green biliary tree we've incorporated in the back. Also, it looks like a few of the Union soldiers have brought back some good old-fashioned 1776 spirit with that old Yankee mantra, "Don't tread on me." Scaly snakeskin, of course, is a recurring symbol for sclerosis. The sclerosis of PSC, for instance. While PSC has been found in a few patients with Crohn's disease, it's far and away more strongly associated with ulcerative colitis. In fact, as many as 70% of patients diagnosed with PSC have previously diagnosed ulcerative colitis. I think it's time to hear the Confederate side of the story, don't you? Crohn's disease is a chronic inflammatory condition of the intestinal tract that affects a little under 1 million Americans. Unlike ulcerative colitis, Crohn's can affect any part of the gastrointestinal tract, from the mouth to the perianal area, but not continuously like an ulcerative colitis. That's why, at Sketchy, our recurring symbol for Crohn's is a cobblestone road, not continuously paved, mind you. The cobblestones appear in patches, see? On pathology, you can often see multiple separate, sharply delineated areas of disease, resulting in the skip lesions that are characteristic of Crohn's disease and can differentiate it from ulcerative colitis. The deep linear ulcers that sometimes meander and connect also give the bowel a cobblestone appearance, in which diseased tissue is depressed below the level of normal mucosa. Like we mentioned before, Crohn's disease is unique in that it can affect any portion of the GI tract, as opposed to ulcerative colitis, which involves only the rectum and colon. So we've added 2 archways at each end of the Crohn's cobblestone path, a mouth at one end and an anus at the other. Watch your head on that one. It really is that small bowel, however, that sees the worst of it, as about 80% of patients with Crohn's have small bowel involvement, especially in the distal ileum. This is why our Crohn's cobblestones made an appearance in our small bowel sewer sketch, toward the bottom, which is meant to remind you of the distal ileum specifically. Just like in ulcerative colitis, autoantibodies are at work here. This time, floating around in the serum are anti-Saccharomyces cerevisiae antibodies, which is a mouthful, so just remember anti-Sac antibodies, represented by this sac attached to the end of this antibody stick. Leaving early, I guess? He knows what's up. Serum markers are not specific enough to differentiate Crohn's from ulcerative colitis, however. Diagnosis of Crohn's disease is still focused on finding the clinical and histologic features that are unique to it. Let's discuss a few of them now. Patients with Crohn's typically present with the usual IBD symptoms: colicky abdominal pain, diarrhea, weight loss, fever, but this time the abdominal pain tends to be more localized to the right lower quadrant, reflecting the location of the ileum and cecum, the most common location of inflammation. So not only do we have this Confederate soldier here, getting smacked on that right lower quadrant with shrapnel, we've placed the entire Crohn's disease scene in the lower right area of the sketch. Anatomical right, of course. Additionally, while microscopic bleeding is common in Crohn's, gross hematochezia is less common. So, we won't go crazy with the blood this time. Because bile acids are normally reabsorbed in the distal ileum, Crohn's disease often leads to significant losses of bile acids due to impaired reabsorption. Without bile acids, malabsorption of fat and fat-soluble vitamins results. See that muddy water there? It's foamy, kinda chunky, just not absorbing properly. This can lead to significant weight loss. On histology, Crohn's is also unique due to the formation of non-caseating granulomas. At Sketchy, macrophages are macro cages. So the aggregation of macrophages inside a granuloma is symbolized by an aggregation of cages, like this group of courier pigeon cages. One important aspect of Crohn's disease is that it causes transmural inflammation of the bowel, involving all of the layers of the intestine, rather than just the mucosa and submucosa. See the wall? Its entire thickness has been penetrated. This explains some of the clinical features that are more common in Crohn's than ulcerative colitis, such as stricture and fistula formation, as well as bowel obstruction. The transmural nature of the inflammatory process results in fibrotic strictures, as the entire thickness of the bowel wall can swell up from inflammation and cause narrowing of the lumen. Radiographically, bowel wall edema and stricturing may create a string sign in the terminal ileum, just pulling it tight. If these strictures become severe enough, they can even cause bowel obstruction. In fact, bowel obstruction secondary to stricture formation is the most common indication for surgery in Crohn's. In addition to strictures, patients with CD can also develop fistulas. This is because transmural inflammation can lead to epithelialization across the bowel wall. And since fistulas are aberrant communications between two epithelialized surfaces, abnormal connections may form between the bowel and other organs, such as the bladder, skin, vagina, or even other portions of the bowel. Remember that Crohn's disease may cause inflammatory lesions anywhere along the GI tract. And I mean anywhere, even the mouth and anus. In the mouth and esophagus, patients may also develop aphthous ulcers. So let's add some small erosions to that oral archway. For perianal disease, think back to our Panama anal canal video, in which we illustrated perianal skin tags, anal fissures, perirectal abscesses, and anorectal fistulas, all of which are manifestations of Crohn's disease. If you're thinking IBD and you see anything about the anus in the question stem, think Crohn's. Let's finish up our discussion of inflammatory bowel disease over at the Medic Tent, where we'll review some of the important extraintestinal manifestations of these disorders. See those wrapped joints? The most common extraintestinal manifestation of inflammatory bowel disease is arthritis. When seen as an extraintestinal manifestation, arthritis primarily affects the large joints and affects multiple joints at once. This is called a migratory polyarthritis. Arthritis affecting the spine, such as sacroiliitis or ankylosing spondylitis, can also occur. In IBD, arthritis is typically associated with levels of HLA-B27, which makes sense because it's also elevated in patients with similar types of spondyloarthropathies, such as ankylosing spondylitis. Skin findings are the next most common extraintestinal manifestation of IBD, and there's a couple to know. Erythema nodosum is a painful erythematous nodular rash that's usually seen on the shins. It's caused by circulating immune complexes which generate an inflammatory reaction of the fat cells under the skin, leading to those classic tender nodules. On histology, you'll see radial granulomas, which are well-defined nodular aggregates of macrophages. Even nastier than erythema nodosum is pyoderma gangrenosum, which is a misnomer since it's neither infectious nor gangrenous. It's actually an inflammatory and ulcerative disorder of the skin caused by dysfunction of abnormal neutrophils, which cause these large, nasty-looking but sterile ulcers that commonly occur on the legs. So don't worry, son. That's not gangrene. Besides shrapnel and buckshot, renal calculi can also be a problem. It involves increased absorption of oxalate. Check out our calcium stone gold rush sketch for those sweet, sweet deets. Lastly, eye manifestations are relatively commonly seen in IBD. Whether it's anterior uveitis, iritis, or episcleritis, they all present the same way, with eye pain and redness. Eye manifestations are typically more common with Crohn's than with ulcerative colitis. Treatment of IBD is pretty similar whether you're talking about CD or UC. The focus is on stopping the inflammation. That means plenty of NSAIDs including sulfasalazine or mesalamine, which are forms of 5-ASA. Just the five-pointed star of the good old US of A. Corticosteroids are used as well, and in refractory cases, big guns like the immunosuppressants azathioprine, 6-mercaptopurine,